Hello, everyone. My name is Tom Osborn, and I am really excited to share with you about how we are using data-driven insights and building digital tools to make mental health intervention scalable for young people in Kenya and hopefully around Africa. So, as we all know, there is a global crisis of mental health around the world, and especially in low-income countries like Kenya. Many young people struggle with common mental health problems like depression and anxiety, yet care is neither affordable nor accessible. There are factors like a lack of enough providers, stigma, and high costs that make mental health care, inaccessible. So our goal and our mission at Shamiri and a part of our Shamiri research group is to make mental health affordable and accessible for everyone, starting with Africa. And to do this over the last 6, 7 years, we have developed what we call the Shimuri model, a model for youth mental health that we think is pretty effective in designing and deploying scalable mental health interventions at scale. And so the way this model works is that it has three important components. So the first component is the using of lay providers through task shifting. So we basically train 18 to 22-year-olds to serve as lay providers. They are trained for about 10 hours only. And after these 10 hours of training, in addition to weekly supervision, they are capable of delivering what we call low-touch interventions, which are brief, destigmatized, and evidence-based interventions, which rather than targeting psychopathology, tend to target overall human functioning. An example of one of these interventions is growth mindset intervention, which tells young people that they can grow and that their attributes are not fixed but can be improved through effort. Another example is gratitude interventions, which tell young people to notice the small things that are happening in their lives and to kind of practice gratitude. And there is a lot of evidence now that this type of low touch therapy, which are obviously less stigmatizing and obviously can be delivered by lay providers like the ones we're using, can be effective, for providing mental health care and mental health solutions. And we know, though, that this low-touch therapy and lay providers are not effective for all forms and all severity of mental health problems. That is why the third part of our model is a tiered caregiving model, which basically allows for the escalation of severe cases to more professional experts. So we work with social workers, folks who have a diploma or a bachelor's in mental health and psychology, and we have them supervise and train our lay providers, but also additionally, we have them take on more severe and escalated cases. So in this model where we train 18 to 22-year-olds to deliver effective low-tech therapy, we have a tiered care approach, and we work in communities, especially in schools, allowing people to access care where they are. So that is just some background of who we are and what we're doing and our model, here at Shamiri. And over the last 6, 7 years, we have tested this, model quite extensively in various in various forums. One of the things we've done is we have conducted multiple gold standard RCTs, which have been published in journals like JAMA Psychiatry, The Lancet, etc. And what we have shown in these clinical trials is this model helps to significantly reduce depression and anxiety symptoms, and that more importantly, the effects are comparable to those of standard psychotherapy, and the improvements can last up to 7 months. And so we're really excited about this, and basically what we're trying to do with this data prize, with this initiative, is to build on top of this evidence that we've built, generate more insights to see how we can move from just these clinical trials to real-world implementations, and to basically develop and build open access digital tools that can allow us to then be able to deploy this not just in Kenya but around the world. So I will now transition to talk about what we want to specifically do with this prize. So we do have two broad objectives. Our first objective is we have already shown that the interventions can be effective in clinical contexts and research trials, but can we show that they can be effective in real-world implementation context? Fortunately, we do have some existing data sets that I'm going to talk about that can allow us to be able to do this. And we also are implementing this model in the real world as we speak, allowing us to gain real world implementation data through which we hope to gain a lot of insights on intervention effectiveness in real world context, and also be able to measure what are some of these things which are driving intervention effectiveness at an individual level. And the second thing which we're really excited about is we want to build a digital tool, which currently we're calling Cheruiyot S, which will leverage this existing database to basically be able to provide real-time insights to empower decision makers, be they clinicians, policymakers, school administrators, parents, etc., with the data that they need to basically, operate. And then importantly, we are going to leverage our existing data set to build a large language model AI tool which can be used to effectively train and supervise the lay providers, such as the lay providers that we use here at Shemiri. Just given that lay providers and task shifting is an increasingly popular approach to reducing the mental health treatment gap, we are super excited because we think this tool, which we will make open access, can be very effective not just for us, but for other providers in Africa and more broadly. So let me talk about the first objective, which is generating insights on intervention effectiveness in implementation context, as well as understanding the individual differences in these outcomes. So we are all about scale. So we know that this type of interventions can work on clinical and research settings. And the question is, can we make them work in the real world settings? And so to do that, we think that we need to generate a robust pool of insights that can be able to not just look at efficacy, but also just look at other variables and factors which are important in scaling up, more broadly. And so the analytical approach that we will use will more broadly try to answer four questions, which we call the four enoughs. And so the first enough, which we call good enough, will be trying to test, does this intervention actually reduce depression and anxiety outcomes? And here we will leverage multi-level hierarchical linear regression models to be able to account for this. The second thing is the big enough. And so under big enough, we're really trying to see the full potential of this model. So in what context does it work best for? Does it work across all schools? So does school location matter? Does resources matter? Does it matter be it that a student or a youth is in an urban or a rural context? And so we will conduct analysis on our existing data set to be able to answer this question around what circumstances do this intervention approach works best for. And then the last two things will be on what we're calling simple enough, and here we're really looking at implementation outcomes. We're looking at things like fidelity, sustainment, penetration, stigma. So the type of things we're looking at to see if other organizations and other people can be able to implement this model very simply. And finally, in the cheap enough, when we use a micro-costing approach to do a cost effectiveness analysis that will allow us to understand how and if these interventions work. So more broadly, we believe that using pre-existing data to measure all of these four things will allow us to adopt an analytical approach that tells us if this intervention works in real-world context. So very quickly, I'll talk about the type of data sets that we have. So we have three data sets that we're going to deploy for this. So the first, which we call it data set A, we collected it from a study where the Shemiri model was implemented by organizations which were trained through a train-the-trainers approach. And so this was a single-arm real-world dissemination study with 3,226 youths aged between the ages of 13 to 25 across 3 counties in Kenya. This data includes measures in depression, anxiety, social support, optimism, etc. The second database is also pretty similar to this. It's just from a different partner organization, this time the one that was working in Kisumu and Nakuru, and similarly it measures depression, anxiety, social support, other type of outcomes. And then finally, we have this third data set, which is also similar to that, from different implementation partners measuring the same thing. So we will deploy this already existing data set to answer this question. Finally, we will do a subgroup analysis to understand individual differences in treatment outcomes. So we will explore how individual level explanatory variables like gender, age, income, affect and influence treatment effects over time. And here we will use a variety of methods, including classical moderator analysis, tree-based modeling, etc., interaction modeling, to be able to just develop a robust understanding of this. So we think these insights will be really crucial as we move towards personalization of mental health, as we start to understand for whom and under what circumstances these interventions work best for. And what we're really excited about is, apart from using this pre-existing data, we will be implementing in June, July, and August of this year with about 50,000 students across diverse counties in Kenya. We can be able to then put these insights into the real world and see if they hold in a new sample size. We're really excited about this and we're really ready to go. Second is building Cheruiyot OS as a digital tool for lay providers and decision makers. And so basically, we are envisioning a digital tool that can leverage existing data sets to one, train lay providers and also empower decision makers. And we've built this, apart from the ones I shared, we also have data from 2018, 2019, 2021, and so we have a rich data set, implementation and research context, which have been done both by us and through community partners. And so what we're trying to build with this Cheruiyot OS is one, precision care. So basically being able to use the data to match young people with the right type of intervention, and providers using models based on symptom severity, type, socio-demographic data. So basically leveraging the type of analysis that we just talked about on Objective 1 to inform Objective 2. What we're really excited about beyond this precision care is that we're going to use an LLL model to basically build an AI tool that can be used to train and support lay providers. So right now we do have audio recordings of about 20% of all of our sessions. We also have treatment and outcome data on the youth to go through a programming, and also the providers themselves. And so using this data, we can be able to automate supervision, automate training, and be able to do some things like measuring treatment, fidelity, etc. And then finally, on the digital hub, we want to build an intuitive hub where all of this data can be visualized and insights and reports can be generated. We want this to be usable not only by the clients, or the young people going through programming, but the parents, the schools, the lay providers, the supervisors, and the organizations and implementers that are bringing this type of like work into the real world. And so basically, just to quickly show how we will build the AI for training lay providers, we're happy to talk more about this during the Q&A section. We're basically leveraging existing data sources, which include session recordings, intervention outcomes, provision feedback, and we're using this to build an AI enhanced training system that includes real-time feedback, automated supervision, personalized learning, and we will be kind of like looking apart from intervention outcome. We'll be looking at things like fidelity, engagement, supervision, supervisor assessment ratings, etc. And so we want to do this in a very data-driven way. And so once we build this AI model, what we're hoping to do in June, July, and August of this year is to conduct a cluster randomized trial where we will randomize lay providers, we'll randomize youth to receive the intervention from lay therapists who've been trained with this enhanced training and have the Cheruiyot OS success, and then lay therapists who have just like a training as usual, where they don't have just have standard training without Cheruiyot OS. And assessment metrics that we will use include feasibility, acceptability, depression and anxiety outcomes, and cost effectiveness. Finally, I just want to talk briefly about the architecture of the digital hub. We are really happy and excited to talk about it in the Q&A questions. Basically, in our discovery phase, where we've done things like field operation, immersion, process, documentation, shadowing, we've already been able to do a lot of workflow mapping and architecture planning around this. And so the type of architecture that we want is we're trying to emphasize architecture that is scalable and modular, that is compliant and secure, and that has future-ready APIs, right? And so basically the idea is moving from where we are now through iterative development, testing and validation, and eventually deploying an iteration. But the hope is to make this an open access tool. Obviously, we want to do all of this in a manner that is ethical and at the SDA levels of like data protection. And so, obviously, we will get ethical approval from relevant IRBs and from the NACOSTI board in Kenya. We will obviously regularly monitor to ensure compliance with the standards. Is setting up a data safety and monitoring board yet really allow us to do this. In terms of data and privacy, we are using anonymized encrypted data sets to protect participant information, and we have a very robust consent process, especially for minors who are participating in our programming. To summarize, the questions that we're trying to answer, from this using existing data set that we have and new data from implementation is what are the real world applicability of our intervention? Can we get these insights and intervention effectiveness in real world context? Can we also understand the individual differences in outcome? Can we figure out for whom and under what circumstances interventions, kind of like work? Can we build Shimiri OS and as part of it have an LLM that is trained to offer personalized training and supervision, for lay providers, leveraging our existing audio recordings as well as our data on efficacy and outcomes? And finally, can we also build an insight digital hub that provides real-time insights to inform decision making on the ground? Really excited about this. We think we can do it, and we are also really pumped about the potential of this being an easy access, open access to. Finally, we believe that those closest to the problem are close to the solution. Our team, including myself, folks who have lived experience of depression and anxiety, we have already, done a lot of work through human-centered design approaches. We've engaged, experience with lived experience, through focus group discussions, through human-centered design workshops, and we're really committed to ensuring that our work is designed in a manner that amplifies the voices of those who are closest to the problem. We are building and developing in Kenya initially, but we want to expand in Africa. And we do think that our open access tech solution can not only be impactful in Africa, and we're going to be doing experiments hopefully further down the line in other geography and context, but we also believe that this can be used around the world, right? And this can be a system and a solution, that is pretty effective. So we have a big team that is working on this, but I'll just highlight 4 people who are really driving this. One includes myself. So I have been working in mental health now for about 8 years, running Shimiri Institute. We are the largest mental health provider in Africa. We serve over 100,000 young people every year. And we're led by Dr. Christine Wasanga at Kenyatta University, but she works closely with Dr. David Tate at University of Nairobi. We also have other collaborators at Harvard University, such as Professor John Wise, who's a real expert in these WISE interventions. Shadrack Lilan is our head of tech, so he, together with Chami at Young, our product leader, the ones who are working day to day to build the digital S and the digital hub. In addition, as we highlighted in our presentation, we have statistical experts, Professor Thomas Rusch from the University of Vienna and Isaac Mbiti from the University of Virginia, who are supporting us. And apart from this team, we have existing relationships with collaborators at universities like Harvard, Duke, Strathmore, as well as funders including the Templeton Foundation, the French Development Agency, Cheruiyot Foundation, and many others. So thank you so much for listening to our talk. We're really excited to be part of this process, and we really look forward to your questions. Thank you.